today's talk is we're very excited about it, and it's really a joint venture between two COBRIs, the Center for the COBRI on Opioids and Overdose, as well as Peter Monte's COBRI at the Center for Alcohol Addiction Studies, entitled the CADRE, Center for Addiction and Disease Risk Exacerbation. It's led by not only Peter Monte, but Jennifer Tidy and Jazz Alawalia, established in 2019. The mission is to become a national leader in substance use, biobehavioral research, and chronic disease manifestations in vulnerable populations. So with that, I will hand it over to one of our star T32 fellows, Brandon Del Pozo.
Hey, thank you, Dr. Rich. So my name is Brandon Del Pozo. I'm a postdoctoral fellow at the Miriam Hospital and the Warren Alpert School of Medicine, and it's my pleasure to introduce researcher Dr. Valerie Earnshaw here today. I saw her giving a talk on stigma at a NIDA JCoin event and knew that she'd be an invaluable resource for the folks back in Rhode Island. And so after a few months of wrangling, we were able to get her here today, and we're really excited. So Valerie said, Dr. Earnshaw said, if you say stigma and social psychologist, you'll have covered all the bases and I can just get on with my presentation. She's not going to get off the hook that easy by way of introduction. She comes to us from the University of Delaware College of Education and Human Development. The work you'll be hearing about today comes from her mentored career development research grant, her K, to study stigma that arises from disclosures about being in recovery for substance use disorder, which is, extremely timely. But I did want to give a caveat. To characterize Dr. Earnshaw as being in training when it comes to stigma or any of that is quite a misnomer. It's true that her K research involves training in substance use disorder, in social network theory and intervention science. But before Dr. Earnshaw embarked on any of that, she was a foundational researcher in the stigma of HIV. Just by way of example, her review of HIV stigma mechanisms has received over 800 citations in the literature. Her original development of an HIV stigma framework has received almost 500 citations. And this is all prior to turning her attention to the specific problem of substance use and stigma and recovery per se, right? So we all contend as researchers with the effects of stigma on people seeking treatment, on the attitudes of people towards the most effective forms of treatment, on adherence and retention in treatment. We're in the midst of the worst overdose crisis in history, and stigma at every step is holding back our best efforts. So we have before us today Dr. Earnshaw, who started with very foundational work on HIV stigma and then pivoted to important work on stigma and substance use disorder. And that's what she'll be talking about here today. So I guess we asked to hold our questions till the end, put them in the chat box or the Q&A. We'll get to them. But in the meantime, it's my pleasure to turn this over to Dr. Earnshaw. So welcome.
Well, thank you, Dr. Del Pozo. That's like the most generous and really kind intro I've ever gotten it. Between all the flooding and Texas and, recovering, the overdose Remembrance Day earlier this week. It's like a tough week. So that's a really nice highlight for the day. So thank you very much for that. Let me go ahead and share my screen. Okay. So again, a big thanks for the intro and a big thank you to everyone for the introduction to join you all today. I'm very much looking forward to chatting with you and connecting about stigma associated with substance use disorders, as well as some of our work on disclosure processes, especially as we're kicking off National Recovery Month. This is a good way for me to get started this month. I'm going to start us off today with a brief overview of stigma. And then I'm going to summarize some findings on substance use stigma from the broader literature. I'm going to do just like a very quick peek at some of the results on disclosure processes that we've been finding here in Delaware. And then I'm going to wrap us up with some work on stigma interventions. And I'm going to use this bar at the top of our slides to orient us as to where we are in this lineup. So starting with our overview of stigma. What is stigma? Goffman, who was a sociologist by training, provided us with this early definition of stigma, which is that stigma is social devaluation and discrediting associated with a mark or characteristic. Now, because Goffman used this mark or characteristic terminology, we often hear people refer to stigmas, by which they typically mean these different devalued characteristics. And unfortunately, we have too many examples of marks and characteristics that are socially devalued and discredited. So they include things like physical illnesses, like maybe HIV, mental illnesses like bipolar disorder, what social psychologists like myself sometimes refer to as social norm violations, like diverse sexual orientations and gender identities, and some socio-demographic characteristics like certain racialized groups. And today's focus is on substance use. I did cheat and put it into multiple boxes or multiple columns. It has to do a little bit with the functions of stigma, which we'll get back to in just a few slides. But when we hear people talk about stigma, they're not always referring to a specific group or a specific mark. They're often referring to a broader sort of social phenomenon. And that's because theorists since Goffman have really honed in on this social aspect of stigma. Theorists have highlighted that stigma results from a social process in which certain marks are constructed as indicators of tarnished character. And then these marks are used to justify discrimination toward and power loss of people who are living with them. So this means that today when I'm talking about stigma, I'm talking less about these individual marks or these stigmas and more about this broader social phenomenon that results from this social process. Now, why does this social process exist in the first place? So theorists have proposed that there are three primary functions of stigma. These include to keep people down, away, and in. And I think that two of these, at least pretty neatly, apply to substance use. So keeping people in refers to the enforcement of social norms. People who deviate from our social norms are sometimes characterized as immoral. Substance use stigma has been identified as a pretty classic example of keeping people in, a sort of societal attempt to stop people from using substances in ways that society has deemed unacceptable. LGBT stigma, sex work stigma, these are other examples of keeping people in. Keeping people down refers to exploitation and domination. So some groups in society have less power and resources than other groups, and then stigma helps to perpetuate these power and resource differences. Now, I mention this because we have examples from history of substance use stigma being sort of wielded to keep some racialized groups oppressed, such as using stigma to oppress Native Americans in the 18th century, Chinese immigrants in the 19th century, and Black people in the 20th and 21st centuries through our war on drugs. So I think we can't really talk about substance use stigma without talking about how it's used to keep people down. Now, when we're talking about where stigma comes from, I just want to pause on something that I've been kind of mulling about this summer and thought I'd share some mulling with you. So evolutionary psychologists often talk about stigma as this social process that people are participating in that's at least happening sort of somewhat unconsciously. It's sort of like the water in the fish tank. So as the fish, we're surrounded by it. It's serving its purposes, but we are not always paying attention to it. And some of the fish aren't even aware that it exists. But some sociologists like Sam Friedman and others have been reminding us for years, some for decades, that stigma is sometimes something that is very consciously and very deliberately constructed for a purpose. And sometimes this is scapegoating. So Patrick Radden Keefe's Empire of Pain, which was my self-assigned summer reading, it chronicles the Sackler family and their role in Purdue Pharma and OxyContin. And it has some really interesting examples of this scapegoating. So rather than admitting that there was any problem with the way that they were pushing OxyContin that would lead people to develop addiction to the drug, Keefe describes how the Sackler family pushes this narrative of people with addiction to OxyContin as abusers, as culprits, as reckless criminals. So here in this book, you can see the Sacklers constructing or creating stigma for a purpose that served them. And we'll come back to interventions later, but I'm just introducing this idea here because I want to plant the idea that if the Sacklers and others can create or construct opioid use stigma, then we should be able to deconstruct it as, smart, motivated people. We can do something about it. Okay, so off my soapbox, I promise. Let's get back to the science. How does stigma impact health? So the process linking stigma with health outcomes is pretty similar across a wide range of stigmatized statuses. So I'm going to share a pretty broad cross-cutting conceptual model with you. This model starts with this social process of stigma that we've been talking about. And then this social process of stigma, it's manifested, which essentially means that it's expressed and it's experienced within structures and among individuals. Now, these stigma manifestations are a good place for us to focus our attention and research because they are measurable and they are changeable. Broad social processes like stigma are difficult to quantify. They feel rather abstract, but we can quantify stigma when it's experienced within our structures and within individual people. So we can use surveys and scales to do that. And we want to measure stigma so that we can understand how bad or how strong it is, how it's impacting our health outcomes, and whether our interventions to change stigma are actually working. Stigma manifestations are also changeable. So we do have evidence-based intervention tools that we know can either reduce stigma manifestations or protect people from them. So these stigma manifestations are also really good intervention targets. So stigma manifestations exist at multiple social ecological levels. So structural stigma is defined as societal level conditions, cultural norms, and institutional policies that constrain the opportunities, resources, and well-being of the stigmatized, and Hudson Buehler and others have been doing a lot of great work in this area. At the individual level, so among individual people, we often differentiate between perceivers and targets with the recognition that there's some overlap here. But perceivers are typically thought of as people who don't necessarily live with the stigmatized characteristic, and they may perpetuate stigma. So this could include our medical doctors, our employers or coworkers, our friends and family members, and just our community members in general. So perceivers may endorse prejudice, which involves negative emotions and feelings like disgust or pity. It involves stereotypes, which are group-based beliefs that are often applied to individuals, and then discrimination, which is poor treatment of individuals. Targets are people who live with the stigmatized characteristic themselves. Targets include people who are living with substance use disorders, or people who use drugs, or people in recovery. So they may experience internalized or self-stigma by endorsing negative beliefs and feelings associated with stigma and applying them to the self. They may experience enacted or experienced stigma, which includes all those experiences of discrimination that have happened in the past or maybe are happening today. And then anticipated stigma, which refers to expectations of discrimination in the future, like expecting to experience poor medical care at some point. If we return to our figure, these experiences of stigma are in turn related to a suite of mediating mechanisms. These are really just processes that link our experiences of stigma with our health outcomes. So we know that these different stigma manifestations are related to access to resources. So for example, they prevent people from accessing treatment, from being hired for jobs. They compound social isolation, and then they lead to psychological responses like depression, stress, and avoidant coping. And then together, these mediating mechanisms can lead to substance use and also undermine treatment and recovery outcomes among people who have substance use disorders. Okay, so now that we've got some of the Stigma 101 down, we're going to turn to the literature and think about some of the research findings that we have on substance use stigma. I'm going to summarize some of our findings on stigma and substance use related outcomes at each of these social ecological levels that we've introduced. So at the structural level, the war on drugs is one of our most commonly cited examples of structural stigma. These policies are critiqued as treating people with substance use disorders as criminals rather than as people with chronic illnesses. And they lead to increased risks of incarceration, which can impact people's health and recovery. An additional example of structural stigma that's been getting attention lately includes barriers that exist to prescribing or accessing evidence-based treatment. So some folks have been characterizing the X waiver as a form of structural stigma. So as you know, US law requires a prescription to, or requires prescribers to obtain a waiver, the X waiver, for outpatient prescription or prescribing of buprenorphine. And this X waiver has been critiqued as restricting access to a life-saving medication. So this is a graph from a paper by Jones and colleagues that highlighted counties with at least 10 or more opioid overdose deaths. And the green ones are counties that have one or more buprenorphine provider, but the black ones are counties with no providers. And what the authors were trying to highlight here is this sort of geographical disparity or a treatment access desert. These places in the South and the Midwest where opioid overdoses are happening, but access to buprenorphine is limited due to this form of structural stigma. So across many disease contexts, stigmatizing policies shape whether people have access to life-saving resources. Now, at the level of the individual perceiver, so these are people who don't necessarily have a substance use disorder themselves, researchers who have studied prejudice, that affective or feelings component of stigma, have found that prejudice towards people with substance use disorders is characterized by contempt and experienced as feelings that express moral outrage. So this would be things like anger, disgust, hate, and blame. Stereotypes, which again is that cognitive or that belief component of stigma, these are characterized by perceptions that people with substance use disorders are perceived as dangerous, unpredictable, responsible for their condition, and not capable of decision making. And then in terms of discrimination, research has identified and characterized discrimination towards people with substance use disorders in a wide range of contexts. So healthcare, employment, housing, friendships, family. Stigma within healthcare settings can have tremendous implications for health. So I just want to take a quick moment to highlight some findings that are particularly relevant to healthcare providers here. A systematic review from 2013 reviewed evidence across several studies focused on healthcare providers, and they found evidence that providers endorse stigma or stereotypes about people with substance use disorders, that implicit or unconscious prejudice is associated with greater intentions to leave one's job, which has implications for job turnover that can undermine the stability of our treatment settings, and that providers who endorse more stereotypes and prejudice may be providing lower quality care. In our qualitative work, we've been particularly worried about stigma in healthcare settings. People in our studies have described striking examples of stigma, especially in emergency medicine settings or other settings where they might need some sort of pain management, like if they're undergoing a surgery. An adolescent participant in one of our studies was discharged after an overdose with a note from their ER doctor saying, "Stop taking drugs because they will kill you or hurt others." And the mother of this adolescent was furious at the doctor. She pointed out that a discharge for a different kind of health emergency that involved a relapsing chronic illness really would or should involve recommendations for further treatment, maybe a referral. And this mother identified stigma as a major reason for getting this pretty outrageous discharge summary. Okay, so ending with targets of stigma. So these might be people living with a substance use disorder. People with substance use disorders experience pronounced shame, which is the emotional core of internalized stigma. And they anticipate and experience stigma from others before, during, and after treatment. And these experiences of stigma have implications for both continued substance use as well as treatment access. Now, I've been focused on stigma experienced by people with substance use disorders, but I'd like to take a moment just to emphasize that stigma is a risk factor for substance use among people experiencing stigma associated with a wide range of stigmatized statuses. So here are just a few examples of studies from the LGBTQ and the race stigma literatures. And this research suggests that people who experience enacted stigma, so again, that's discrimination or poor treatment from others based on their sexual orientation or gender identity or their race or ethnicity, they cope with these experiences via substance use, including alcohol, tobacco, marijuana, and other substances. And stigma has been related to both the likelihood of use as well as more frequent or disordered use of substances. And among people with substance use disorders who are in treatment, we also see some evidence that stigma is associated with more substance use. Now, if we turn to associations between stigma and treatment outcomes, the qualitative literature is fairly consistent. So when we talk to people about their experiences, they tell us that when they internalize more stigma and when they anticipate more stigma, they're less likely to start treatment. So this first quote was actually from a high schooler with an opioid use disorder. These data were ones that we collected up in Boston. The participant told us that they didn't want to get help because they were scared of what people were going to think in high school, because you're very scared about being judged. And, especially in high school, that people are going to talk. Qualitative results also suggest that stigma is associated with lower treatment adherence, which you can start to see in the second quote from a participant down in Delaware. This participant said that the person they disclosed to doesn't like me on Suboxone and told me to come down off it and not stay on it for long because it's bad for my body. After I told her, I started coming down that week. So this wasn't a medically prescribed or recommended tapering. It was because a family member told them to come down. But interestingly, the findings are more complex when we start to look at the quantitative data. So when we look at studies that are based off of surveys and other type of data, we have some findings suggesting that people who experience more stigma delay seeking treatment, but then we also have findings that suggest that people who are in treatment experience more stigma. We have some findings suggesting that people who internalize stigma are more likely to drop out of treatment. But then we also have findings that people who have internalized more stigma stay in treatment centers longer. We also have a lot of null findings, meaning that stigma was not associated with a treatment-related outcome in a study. Several reviews of the literature conducted in the last decade have concluded that findings on associations between stigma and treatment have been mixed, which is really interesting to me as a stigma researcher, because in other areas like HIV, the findings on stigma and treatment are becoming clearer and clearer, that people who internalize more stigma, who anticipate more stigma, are less likely to initiate care, start medications, and stay in care. So what might be different here? Thinking broadly, to me, these findings suggest that there are factors specific to substance use disorders that moderate or change our more general cross-cutting conceptual frameworks, and that we really need to be thinking more about these moderators as we try to apply what we know about stigma from other disease contexts to substance use disorders. So this might involve taking into account how long someone has been in recovery, what is their recovery identity, how do they think about themselves, do they even think about themselves as being in recovery? It might also involve things like, where is the person? What is the legal or cultural environment surrounding drug use, treatment, and harm reduction where they are? So taking into account some of these other factors, I think may help to clarify why we're getting all of these mixed findings in the literature. So much of the work that I reviewed in this section is summarized in this article. It was published in December. If folks want to read more, it's available online, or you're welcome to email me for it. I'm going to take just a quick moment to talk about some disclosure processes with you, because this is what much of my lab is focused on right now. So I'm excited about it, and might be some good food for thought. In our previous qualitative work, we noticed that disclosure appears to be sort of a doorway or a gateway. And when participants walk through it, when they disclose to other people, they sometimes encounter pronounced stigma, which, if we're looking at our qualitative results, appears to undermine recovery. But we also found that when people disclose, they sometimes find on the other side of that really wonderful social support, which can help to facilitate their recovery. So being able to talk to other people about recovery, being able to tell people at school or at work about, one's treatment for logistical purposes, like for planning one's schedule, appears to lead to better recovery outcomes. So we wanted to try to better understand what's happening with disclosure. And so we turned to the disclosure process model to really try to better understand what characteristics of disclosures might be shaping outcomes of these disclosures. So we had a pretty homogeneous sample, and people were getting very different types of responses. So we wanted to know, why are some people receiving social support and other people are experiencing stigma when they disclose? The model theorizes that people's goals for disclosures, the reasons why they may want to disclose, impact how disclosures happen. So how much people disclose and how other people respond to them, which in turn lead to changes in their social interactions. So may impact whether they receive stigma or social support. And then those reactions can lead to long-term health outcomes. So in our case, we're interested in treatment-related outcomes, but it can also impact the relationship long-term. And then the results of all these individual disclosures, whether they go well or poorly, may shape future disclosures, leading people to disclose more or less in the future. So you can see here that in this model, disclosure goals are quite primary. They're quite important. So we decided to take a closer look at disclosure goals in a study. We focused on approach goals, so trying to achieve a positive outcome when we disclose, like I want to receive social support or I want to make amends. And then we also measured avoidance goals, like I'm trying to avoid judgment or something along those lines. And we tried to see whether these were associated with any of our relationship outcomes, including stigma and social support. So in this study, which Dr. Del Pozo referred to earlier, this was my Career Development Award. We recruited 146 individuals receiving treatment from an opioid use disorder, a local clinic providing outpatient treatment. We talked to them before they disclosed, and we asked them, what are your goals for disclosure, your approach goals and your avoidance goals? And then they came back after 3 months. We measured if they disclosed or not, and also if they were receiving social support or if they had experienced stigma from the person they disclosed to. So we found that approach goals, so wanting a positive outcome from one's disclosure, was associated with greater likelihood of disclosure, and that maps onto previous literature. Interestingly, having avoidance goals, like wanting to avoid judgment, wasn't associated with disclosure, which is a departure from the previous literature on disclosure in other contexts, like LGBT disclosure. We think that this is because, at least in our sample, people who were receiving treatment, who were in recovery, often just had to disclose for some sort of logistical reason, despite being really worried about judgment or possible negative outcomes. Then, just as the disclosure process model would predict, we found that people who had more approach goals going into a disclosure received more social support, and people who had more avoidance goals going into a disclosure received more enacted stigma. And we also did find that people with greater substance dependency experienced more enacted stigma when they did disclose. So this has given us some initial support for the disclosure process model. We found that disclosure goals are associated with whether people receive stigma or social support from others. And we're hoping to collect data over a longer period of time to better understand, the implications for recovery outcomes following disclosures. And we're also working on interventions that are really focused on disclosure goals to help people decide whether they want to disclose or not, knowing that avoidance goals, maybe, if you're really worried about judgment, you may actually experience that. You have a right, to be worried. So we're trying to do some coaching in that area. Okay, so no stigma talk is complete without touching on solutions. So let's dig into stigma interventions. Now, unfortunately, there is no one silver bullet to stop stigma associated with substance use. But we do have many tools in the stigma intervention toolkit. In other words, we have developed a sense of strategies that work to decrease stigma. We have tools to address stigma at the structural level, like by changing stigmatizing policies. We also have tools to address stigma among perpetrators, like things like contact. And we have tools to address stigma among targets, or people living with substance use disorders. And some of these tools reduce internalized stigma, whereas others are designed to help people be resilient to enacted and anticipated stigma from other people. Now, I'm going to take a moment just to focus on a few of these tools to spotlight some evidence-based strategies for you. So one stigma reduction tool is just to aim for policy change at the federal and the state levels. So we can aim to repeal stigmatizing policies, and we have some evidence that health outcomes for stigmatized group members do improve after stigmatizing policies are removed. So for example, the mental health of sexual minority men in Massachusetts improved the year following the legalization of same-sex marriage in that state. We can also aim to enact protective policies like non-discrimination policies. So we have evidence that these non-discrimination policies are associated with better well-being. And so passing these types of policies may improve health. There is a lot of opportunity for change here. Thanks to the war on drugs, we have many policies that need to change to improve well-being of people living with substance use disorders and people who use drugs. Now, one of our most powerful ways to address stigma among perceivers, again, including like the general population, healthcare providers, and others, is through contact. So contact is how sharing our personal stories can change stigma. We have a lot of research on this, and this strategy appears to be effective at reducing stigma associated with many stigmatized statuses, so substance use, race, HIV, as well as others. Contact can happen either in person, like when people interact with and talk with each other, but it can also happen vicariously, like over TV, the radio, podcasts, or books. And research suggests that contact leads to increased empathy and perspective taking with people from stigmatized groups. It also leads to more knowledge, which can lead people to question those stereotypes. And it also then reduces anxiety about interacting with people from stigmatized groups in the future. And in turn, this all leads to lower prejudice or improved feelings towards stigmatized individuals. And lower prejudice paired with reduced stereotypes can lower the likelihood of discrimination, which is often our end goal. There are some important complicating factors here, which is why, in part we observe so much substance use disorder stigma in families and in with healthcare providers, even though they are having a lot of contact. So some of these issues have been highlighted in some recent reviews and kind of provide another example of ways that we need to rethink what we've learned about stigma from other areas when we're working in substance use disorder with substance use disorder stigma. We can also address stigma among targets, people living with substance use disorders themselves. So I often think about bolstering resilience resources for people with living with stigmatized statuses. So these include modifiable strength-based characteristics that may buffer or protect people from the negative impact of stigma on health outcomes. So these would include things like social support or adaptive coping interventions. So the idea here is that stigma may take a while to change. We see that with sexism and we see that with racism. So it's really important to think about how to protect people from stigma while we're all working to try to change it. We do have other tools. We have many other tools. The trick is to figure out how to use these tools or how to implement them in ways that make them most effective. So we have some evidence on how to do this. We know that multi-component interventions that use more than one stigma reduction tool at a time appear to be more effective. We see that multi-level interventions that address stigma at both the structural and the individual levels, and maybe among perceivers and targets, appear to be more effective. And also, very importantly, longitudinal interventions that use our stigma reduction tools over time and reinforce them appear to be more effective. So the bad news is that history tells us that deconstructing stigma isn't an easy or a quick job. Again, that's why we still have some of these big isms that have lasted for a long time, racism, sexism. But the good news is that science tells us that we do have many tools at our disposal to do it. We just need to figure out how to use our tools more effectively to address stigma associated with substance use disorders. Okay, so thank you for your time and attention. It looks like we have plenty of time for questions. So I'm really looking forward to hearing your thoughts and questions and having some discussion.
Thank you, Dr. Earnshaw. I know Scott Newfield has a few questions. So Scott, if you just hang on, I'm going to unmute you so you can ask your questions. There you go.
Hi, Dr. Earnshaw. I did write my questions in the Q&A thing, but I guess that was not the right thing to do. So I can also just say them. First of all, I just want to say thank you so much for the excellent talk. Really, really appreciate you grounding all the work that you're doing in intersectionality, the historical, structural perspectives stigma, the reference to scapegoating. I think that's just also important, especially in a field that tends to be very individualized when we talk about stigma, what it is, and how to address it. I guess I had two questions. I'll start with the first one. The one is sort of, there's some debates, I'm sure you're familiar with them, about terminology, substance use disorder, the sort of chronic relapsing brain disease model of addiction. And some recent studies, you're probably familiar with the one by John Kelly and colleagues that just came out, I think, last year on, terminology. It was in addiction, terminology, chronic relapsing brain disease, and stigma outcomes. One of the challenges with that brain disease narrative is that it can sort of sacrifice agency and people's perceptions of, I guess you call it prognostic optimism, the likelihood people think someone with a substance use disorder can recover. So there's sort of maybe this trade-off where when we talk about substance use disorder or addiction as a disease, it can tend to sacrifice some of the agency, maybe even the human rights and dignity of people who use drugs or people with an SUD in trying to shift some of the attributions about substance use. Curious if you had any thoughts or comments or research about it, sort of navigating that balance between emphasizing that decreased agency for people with an SUD versus the human rights and dignity of people with addiction.
Thank you so much for raising that. This is a really important point, and there's a few things that it highlights for me. So first, the importance of language. Language feels like a little thing, but the research by John Kelly and others really suggests that the ways that we talk about this does impact how people think and also what people intend to do. So there are stereotypes and there are discrimination. So it's really important to figure out ways to get it right. And one of the things that you raise is also something that I've been thinking about, especially this summer, about like, some of our suggested language, it does remove the idea that like people can be self-directed, that they can choose what they want to do, that they can be trusted to make good decisions for themselves. So I don't have any solutions. I wish that I did know, because if I did, I would be using better language throughout. But I wish that I knew the answer. I will say that this is one of those areas where I think that there's room for great research, and some stigma research is very complicated, or it's hard to track people's experiences in the real world and try to understand it and get all of those moderators. But I'm really hoping that people can do some more research to crack these language questions for us. And some of them can be really easy. Like, a lot of these are just classic vignette studies. So Scott, please go do the research or back, or you and your team, and tell me what the responses are, because I think it really does require some more careful consideration, especially as we're moving into, if we're telling doctors this is like a chronic relapsing brain disease and family members, but then we're also telling them like we're using strategies like decision aids that really are saying, no, people need to be empowered to choose what direction they want to take, or they need to have a choice for harm reduction. We need our language to keep up with recognizing people's autonomy and people's right to choose. So I think that's a really important tension, and thanks for raising it.
Yeah, thanks for the response.
Dr. Earnshaw, we have, first of all, outstanding presentation on a critically important a topic. Another question in the Q&A, someone mentions Linda Mahoney, looking for substance use drug policy suggestions that have been able to move the needle and make an impact on stigma.
Policy suggest. So that's a great question. There's been a flurry of policy related changes. I see Dave Humes is here from my home state of Delaware, where Dave has been a great advocate for policy changes like related to naloxone and other things. And I haven't seen a lot of good research connecting policy change with stigma related outcomes. like there has been in other fields. So so if that's the question, like policy change and stigma related outcomes changing, I haven't seen a lot of work on that yet. The question just disappeared from the Q&A box. I'm trying to see if I answered it, if I'm answering it.
Yeah, it's in the answered
In the
section.
answer, yeah.
You did. Yeah.
So I haven't seen, I mean, we can, based on what we're seeing in the LGBTQ literature, that like most of these policy changes, when people when they change structural stigma, when they change stigmatizing policies, you do see change in how people are experiencing stigma at the individual level, but I haven't seen research on that in the SUD field yet. So more places for us to do research.
Another question was, and then we'll go to Jody. Someone said, I really appreciate your language framing stigma to substance use disorder in an effort not to contribute to stigma, but do you think that it could be oversimplifying things? For instance, not all persons who use drugs have a substance use disorder, but also face stigma. And should we be measuring alcohol stigma separately from drug use stigma?
That is a wonderful question, and thank you for pointing that out. So I use that language mostly because most of my research is with people who do have diagnosed substance use disorders and are in recovery. So my research is maybe a narrower view over it, but that's a really important point, that stigma impacts the full range of people who use substances and are far out in recovery from substance use disorders. So but that's the reason that I used it in this presentation. Should we be measuring alcohol stigma separately from drug use stigma? There are definitely nuances to stigma associated with different substances. So that might be alcohol, but there's the stigma associated even with opioid use disorders versus cocaine versus cannabis. Like the stigma is different. It's both different in its magnitude, how much stigma is there, as well as what exactly those stereotypes and prejudice sort of feels like. So we should be measuring and kind of taking a nuanced view of stigma associated with substance use disorders. I will say that when I look at the numbers of like national surveys, like looking at prejudice towards or like intent or acceptance of discrimination towards people with different types of substance use disorders, as well as some of the experiences of stigma with people with different types of substance use disorders, I'm always really surprised that they're all just really high. I often expect alcohol use disorders to have a little less stigma than maybe opioid use disorders or others, but I'm time and time again, surprised and impressed, and maybe many of you are not surprised, but that they're all high and it's similar. But more nuanced research would be very helpful.
All right, we'll turn it to Jody.
Boy, this was just really a fascinating discussion, and it continues to be a fascinating discussion. And so thank you so much for this talk. I spent a lot of the last 3 decades working with people who had HIV, and then also people with who are incarcerated in and out again, and of course people with addiction. So to me, the stigma is like, it's the major problem. We would never think that it was okay to do the kind of things we do to people who use drugs to anyone else. And in fact, someone told me that the rates of stigma around addiction are higher than almost any other, than HIV, than race or class or anything else. But it seems to me we have a bit of a both a national and an international experiment going on here. Mm-hmm. So one thing that jumps out is Portugal. So 20 years ago, Portugal said, you know what? Addiction is a disease, and we're going to treat it like a disease. We're taking it out of the Ministry of Justice, hand it over to the Ministry of Health, you deal with it. Mm-hmm. And for 20 years, the Ministry of Health has dealt with it. They come up with a plan. Now they're boxed in by, UN treaties around drug use that are crazy. So they couldn't, completely legalize it, but they used a structure where they take people, and if the police catch them with drugs, they get sent to a tribunal. Now, instead of just a purely, a judge who's gonna like say you're a bad person and you get punished, they have a more of a therapeutic tribunal where they have real teeth. They can sanction people and they can tell people what they can and can't do. But the first thing they do is evaluate the person. Who are you? Where are you from? What is your educational background, your work background, your home background, your psychological status, your family connections, what's going on in your whole life? And by the way, do you have addiction issues as well? And of course, many people don't have addiction issues, and they say, well, we don't want you using drugs, so we're going to fine you a lot, and we're going to fine you a lot more if we catch you again. And they put these, constraints on people. Oh, you were hanging out in that club and you got into trouble there, so you can't hang out in that club for the next year. And if you do, then the criminal people are going to come down on you. But if you have addiction, well, we don't fine you, we don't punish you, we don't lock you up. We treat you. We get you into treatment. The whole thing is about treatment. And with that consistent message banging home for 20 years, some really smart people thinking about it and messaging on it and talking about it and doing pragmatic things and getting people hired. They had a wonderful program where they would hire people who had addiction issues, and they would pay them. They would pay, they went to small businesses and they said, hey, here's the deal. We will pay this person if you let them work for you for 3 months, 6 months, something. At the end of that time, you have no obligation. And we are not, I will support them on their addiction treatment and other side, but you just have to let them work with you. If it works out, great. And then at the end of that 6 months, you're free to hire them or not hire them. And it turns out it was a home run. People, once they got to know somebody, well then, okay, that's fine. That's, and so, we have a lot of Portuguese people in Rhode Island, and a lot of them have connections to the homeland, and go back and forth. And they understand this, that, it's treated different over there. Addiction, if somebody has a kid, if your kid has an addiction problem and your neighbors know about it and they talk to her, they say, well, how's your son doing? Is he getting the treatment that he needs? And here, no way, it's completely different. I mean, it's a different culture, but it's all about the stigma. So the point is there's a very different stigma going on in both places. And I think, well, first of all, it would be great to measure it and measure the impact and the associated things. But second of all, when we look at, and to me, a big thing is the incarceration rates. When we look at incarceration rates in the US, I mean, we've got the highest incarceration rates in the world, but not in Rhode Island. That in Texas and Florida and Alabama and other places. And so different states have different rates of incarceration and I'm sure very different levels of stigma. I mean, we still have a lot of stigma in Rhode Island, don't get me wrong. But there seems to be, when you think about a national survey, wouldn't that be great to have a way to measure and correlate stigma around substance use and incarceration and other things. So maybe I'll.
Now you're sweet. Yeah. And you know what? I love this like natural experiment language, because they've done a really beautiful job in the LGBT stigma space. This is Mark Katzenbuehler's and others' work, watching the natural experiment of same-sex marriage roll through and the push and pull around policies, and then measuring, individual, like watching these structural level changes happening and then measuring stigma among perceivers or the general pop, as well as LGBTQ folks. And they've been able to see, how those different levels of stigma are moving together. And so the blueprint is out there. You know, we have the blueprint of how to do it, but I don't know that that we've caught up yet, but I agree. I think that would be really fascinating to see.
It is interesting. I mean, LGBTQ issues, and in particular gay marriage, has really turned around. Like that is a wonderful example of how the culture has changed. And yeah, there's people that are older that still think, oh, marriage is between a man and a woman, but all the young people are like, are you out of your mind? Like, and so it's, and I don't know if anybody's really analyzed how that came about, or how it, I mean, obviously there was really determined and organized and smart activists that pushed on many, many levels. But, a lot of it is the TV. Everybody watched Modern Family, like, oh, okay, well, we have a gay couple, and okay, they adopted. Of course, why wouldn't they?
Yeah.
And so I don't know. I think we definitely should think about lessons learned from gender issues.
Yeah, so there is another question. I want to make sure we get them in before the end. I'm going to read it to save time, from Zoe Brown. Hi, and thank you for the discussion. Thinking back to the graphic you shared, have you noticed these varying correlations between stigma and overall outcomes are related to particular geographical regions? For me personally, I've noticed that people's perception of stigma is associated with stigma growing up in the Midwest were very different from my experiences here in the Northeast.
Yes. So that's a great question. And I'm not sure how much of this research again has been done in in the substance use or field itself, but we do have evidence from other stigma fields that people's experiences of stigma are shaped by their environment. And there's been some really interesting research showing that the effectiveness of our interventions also might depend on how much stigma is there. So within HIV, for example, HIV prevention interventions targeting Black men who have sex with men are less effective in places with high racism. So people are experiencing more stigma. The impact of stigma seems to be stronger on their, it's more harmful. And then also our interventions are less effective. So, and this is such a great conversation, because I think that there's such pronounced structural substance use, stigma. There's such pronounced stigma in our environments. The water is awful with the stigma, and it's also a time of rapid change where there's a lot of opportunity for research.
Yeah, I was thinking about what Jody said with regards to same-sex marriage. I remember when my daughter was very young, she came home and said, oh, mommy, daddy, oh, it's so cool. My friend has 2 mommies. And I was just thinking about, as Jody said, the culture has changed in so many sectors and things accelerated so wonderfully fast, maybe not fast enough for many people, I'm sure. But what about the stigma world? I don't, I'd be a little facetious. I don't, my daughter didn't come back at home and say, oh, mommy, so-and-so's, a heroin user, and boy, how can we teach how to be anti-stigmatist, something like anti-racist, to people and to the youth, because it is the younger generation, like I think Jody alluded to, but I would say that really transforms the landscapes on these kinds of things.
Mm-hmm. So when I think about all stigma intervention, like targeting, perceivers, general pop, I'm thinking about what we can do to change people's hearts, minds, and hands, right? Because prejudice lives in their hearts, stereotypes live in their minds, and they do discrimination, right? So for changing their hearts, those contact-based interventions, sharing stories, like let's get a modern family with a family of folks with substance use disorders, or like a Queer Eye with people who use drugs. I don't know, but sharing these stories is very helpful. There's a lot of research about contact, and contact's one of our best ways for prejudice reduction. Stereotypes is knowledge. I mean, contact helps to change our ideas, but also We have just a really long way to go in terms of educating people. So changing their minds, and then in terms of changing their behavior, changing discrimination, you know, if we change their hearts and their minds, we should be able to change what they're doing, that discrimination. When that doesn't work, I love a good behavioral design, which is just what can we do to constrain people, to stop people from discriminating? And there are things that we can do to kind of like shore up our policies, to think about different decision points that people have when they're interacting with people who use drugs or people in recovery from substance use disorders, to try to remove opportunities for people to stigmatize. The example of this that people often think of is with orchestras. They used to be able to see if, you know, who is trying out, interviewing, I forget the word for orchestras, but so there was a lot of gender discrimination. Once they put the person who was trying out, I wish I remembered this word, behind a screen, so they couldn't tell the gender, men and women are hired at equal levels. So that's tying people's hands. We haven't solved sexism, but we are preventing sexism from impacting people's behavior. So with your, you know, with this generation auditioning, thank you, Dr. Del Pozo, for the right. Yeah, so how can we change people's hearts, minds, and hands is really how I think about it. It's sort of, you know.
Yeah, that was a wonderful way to end. We're at the half hour. On behalf of the excellent work that Gail and Hillary have done, the introduction by Dr. Del Pozo, on behalf of the two Cobries, Jody, Peter Monty, myself, Jen Tidy, and others, and your excellent presentation, Dr. Earnshaw. We wish you the best this coming fall and to continue this great work that you're doing. Thank you very much. There's a round of applause that you can't hear, but there's some of it.
Thanks for the great discussion.
Great. Thank you.